Hello and good evening, good afternoon and good morning to everybody around the world. My name is Adrian Banning. I'm an interventional cardiologist in Oxford. And it's a fantastic pleasure to host this session sponsored by Abbott, which is going to describe modern PCI, how OCT with the new ULTREON 1.0 software supports you in guiding and optimizing your procedure, a calcified lesion. So what we're going to look at today is we're going to look at how using physiology and imaging, we can actually do so much more for our patients than perhaps we could previously with the angiogram. Clearly, there is an interface with these technologies. We need to understand when we should use physiology, when we should use imaging, and how using these technologies, we can select the right tools to get better outcomes for our patients, to move perhaps patients through the cath lab more quickly, and perhaps ultimately also save some money. We've got a fantastic faculty. We've got an absolutely spectacular live case from Madrid, which I urge you to sit and watch. And we're going to really have the opportunity to drill down a little on this really contemporary interface between when we should use physiology, when we should use imaging, and how it can then guide our intervention to make things better for our patients. So I'd like to introduce our panel. We've got Lawrence Raber from Bern, who's, you know, is an expert in imaging. We've got Elvin Cady from Zwolle, who's going to talk to us about how physiology can tell us so much about when to do things, but when perhaps we need to know a little more. We've got Javier and Niels from Madrid, who are going to show us a live case. And we look forward to their input. So with that, I'm going to ask Elvin to show us his presentation. That's entitled, When Physiology Alone is Not Sufficient. Elvin, thank you very much for your participation. We look forward to your talk.
Good morning. My name is Elvin Cady from the Academic Hospital of Erasmus in Brussels. My task is to talk to you about a topic that has become very much in vogue these days, when physiology alone is not sufficient. So when you talk about physiology, the first thing the tool that has the major evidence on this is the FFR, and the FFR concept evolution started from the DEFER trial, which showed that non-ischemic lesions do well on OMT alone, and then it became really widespread when this was tested in multivessel disease through the Cornerstone trial, the FAME trial, which showed that PCI treatment of only ischemic lesions is better than PCI of all angiographic lesions. And then there was a transition in the logica here, and it went from a defer tool into a mandating tool with the FAME2 trial, which said that proved that revascularization of the FFR positive is better than OMT alone. But we have to say that for the primary endpoint was driven mainly by revascularization. And only at long follow-up, there was some positive sign in improvement of myocardial infarction. So we could, from this, we could decide, we could say that the FFR revascularization is a smart way of revascularization in reducing angina, although there was a question of how much this translates in hard endpoints. And this was stated from this was tested from the schema trial. And as you know, an ischemia-driven revascularization did not lead to improvements of major hard endpoints like cardiovascular death, myocardial infarction, or resuscitation for cardiac death. And also here, though, we see, again, this 20% of patients that had to do a crossover due to unbearable angina. So we could see that ischemia detection is clearly associated with reduction of angina, but not of major hard endpoints like cardiovascular death on MI. And the question is why? And this, maybe we could look back to the progression of atherosclerosis. The progression of atherosclerosis is based on rupture and healing and progression of the plaque. So before the plaque will become at least intermediate or severe, it goes through a procession of lipid accumulation, and then the plaque becomes vulnerable. It will rupture the first time, and either it will give us an acute or an overt acute coronary syndrome, or in case this was an occult rupture, it will progress in the plaque healing, which then will present us a stable angina. or crescendo angina. And this is the moment when we eventually will perform an FFR into these patients. And as you know, when we perform the FFR, about 1/3 of them will be positive and the other 2/3 will be negative. So we know that the FFR negatives, once they're treated medically, the majority of them will have a medical treatment which leads to plaque stabilization. However, there are some plaques that persist having vulnerable features, and their prevalence is about 20 to 40%. So from these lesions that we're leaving beyond, let's say only on medical treatment, there are still 20-40% of these that are treated medically, but they remain vulnerable. The question is, what is the relevance of these vulnerable plaques once they are ischemic, non-ischemic? And we have had a very nice study from Dr. Lee representing the experience of Korea and Japan when they looked to patients with FFR positive and negative, and they looked at the CT scan data. As you can see, also here, 1/3 of the patients was FFR positive and 2/3 were FFR negative. And when we look to the vulnerability features in scan, you could see that minimum lumen area, plaque burden, and low attenuating plaque, they were relatively similar between groups, despite one group being negative. And when we look to the prevalence, of course, as the lesion becomes more severe and more ischemic, the chance that it has a vulnerable plaque also augments. But if we look to, so in percentage, these vulnerable plaques are more present in FFR positive, but on absolute numbers, the majority of them, as I said, 2/3 of them will be left beyond despite because they are FFR negative. And if we look to the future events based on these, you could see that the large number of plaques are left untreated, and this translates on a high event rate, even more higher the event rate than the patients that received revascularization. So the majority of events in this retrospective study originated from FFR negative lesions with high vulnerability features. So now we have tools to look at this with intravascular imaging and detect these. And this was done particularly by the combined trial, which I had the chance to present at TCT last year, where we looked to FFR negative diabetic patients and divided them into TICFA, so known predictor of plaque vulnerability, or non-TICFA. And we found that the TICFA patients had a 5-fold incidence of MACE compared to the non-TICFA. Therefore, we can now say that the persisting inflammation and vulnerable plaques, despite having an FFR negative lesions, could lead again to ACS and new clinically driven revascularizations. And that's why physiology alone is not always enough, and imaging should be considered. Thank you.
Thanks, Elvin. That's terrific. Perhaps I could ask Lawrence, the search for specificity with imaging is a challenge, isn't it? That perhaps when we image, we're worried we're going to find 4 or 5 TICFAs in 3 vessels, and we can't stent all of them. And we also haven't proven from the data we've just seen that intervention will change the outcome for these patients. Where do you stand? You're an expert in imaging. Where do you stand with specificity of the findings with regard to plaque vulnerability?
Well, of course, you raised a key question here, because basically, I think we more and more agree that the non-flow limiting lesions that show certain vulnerability criteria like plaque burden, amount of lipids, thickness of cap, that can be detected by various intracoronary imaging technologies or by CT in part are important prognostically. We, for example, just witnessed 2 Lancet publication on the prognostic effect of NIRS that shows an association between lipid and outcomes. And so they are important for prognosis and management. But the key question is how to manage, because we need to bear in mind that the positive predictive value in all the studies that have associated imaging findings and outcomes is about 20%, so 1 out of 5. And that's a key problem, of course. And it differs in obstructive lesion, where you at least have a predictable benefit for the patient in terms of symptom relief, which will not be the case if you treat vulnerable plaques, at least by interventional tools. But of course, most likely it's a domain of medical treatment. And the question is how intense it should be.
Perhaps I could just ask Elvin, in your practice, Elvin, how are you using OCT in your diabetic patients? Are you using more OCT now clinically?
Well, I'm using OCT for two reasons. First of all, because if you are going to treat the diabetic patients, using OCT is very important to see the extensivity of the disease. And as Lauren said, these are not simple lesions. We have very long lesions in these patients. And there are two major reasons why using OCT in these patients. The first of all is if you are going anyway to stent this lesion, you're going to do a much better job, particularly in these patients, to have a good landing and a good geography of your PCI. On the second is with this study, we just shown that this is a problem. We've shown that these plaques will have 5 times more event rate. And we're not talking of any type of vulnerable plaques. These are lesions that are angiographically evident. We're talking about lesions that are 50%. Before we had FFR, we were stenting these lesions. And right now we see that if we see this some type of vulnerability, and maybe TICFA is not the only, these lesions could be somehow addressable. And it's again OCT who could tell us if we should go either for a medical treatment, these are really diffuse lesions, or if we should go for spot stenting sometimes. And I cannot say which is the best thing. This is the next step of research that has to be taking place, but we now individualize the problem, and that's where I stay, also in question of time.
Certainly the challenge of improving our outcomes in diabetics really is long overdue, isn't it? We really need to address that. So with that, we're going to move on to this fantastic case that I'm looking forward to seeing. Javier, I wonder if you could just tell us the clinical details of the case, and we look forward to seeing the ULTREON system in action.
Thank you very much, Adrian. Yes, so this is, we're going to present you the case of a 75-year-old gentleman with exertional angina. He had multiple cardiovascular risk factors, smoking, dyslipidemia, hypertension, diabetes mellitus, and he also had chronic peripheral vascular disease. Now, as I say, the patient had exertional angina. He had also a pacemaker, permanent pacemaker implanted due to a complete AV block in the past. So based on this, combination was sent directly to the coronary angiogram. And in that coronary angiogram, we found that there was a chronic occlusion of the right coronary artery, very well established, very long, and a tight stenosis in the left circumflex, heavily calcified, with a QFR of 0.73, so it was hemodynamically significant, that was identified as the first therapeutic target for this PCI. The syntax score was 24. And he had the APT score of 57. That means high bleeding risk. That means that if we perform PCI, we had to really do a good job. We decided to treat the circumflex, then stage the patient later to see if symptoms persisted and the occlusion of the RCA merit treatment. And with this, Adrian, I'll back to you, and then perhaps we can see the case.
Thank you very much. So obviously, complex patient with potentially complex anatomy and potentially complex medical problems. And as you've made the point, Javier, if we're going to intervene here, safety is clearly hugely important to make sure we do our best job with regard to stent deployment and optimization of medical therapy. So if we could run the first part of the case, please, so that we can see that.
Welcome to Hospital Clínico San Carlos. My name is Javier Escanet, and I have the privilege of being with Nieves Gonzalo today in this case, recorded for EuroPCR 2021. We are privileged to share with you a very interesting case of calcific stenosis, which will be guided by OCT using the most recent development, the ULTREON system, which has very valuable features for assessment of plaque and guiding the procedure. Muy bien.
It's pretty easy.
12 atmospheres, and you can see the waist already.
So 2O will not...
the circ is actually quite a challenging vessel for every device and also for OCT, but you can see that the catheter has advanced very well, even in this circ with this significant tortuosity.
Yeah, I think it's good.
We're going to do 5. We continue then. The next screen is also telling us, reminding us that we need to purge properly the catheter. We purge it outside, but as you can see, some blood got in, so it's always good to check this. And immediately now we go...
And you have a very nice reference at the side, indicating that you have how it should look when you have cleaned the catheter.
The first thing it's going to ask is about the quality of the image. Actually, the system is going to provide some information about part of the parts of or some frames where there is some uncertainty about the measurements, etc. But if we review it and we think it's fine, we can just proceed. And I think it's fine. You can see that there is no blood. I think the quality is pretty good.
It's a superb quality.
Yeah. And so we're going to accept this and continue. Next step is the co-registration. One proximal point that is going to be in the guiding catheter, and then another point distal. The interesting part of ULTREON is that it implements this MLD Max protocol or workflow. So first screen you're going to see is the morphology, and basically is calcium assessment. And you can see here how the system really provides an analysis of calcium that includes the arc of the calcium that you can see, and also the thickness of the calcium, the maximum thickness of the calcium in each frame. And those are, of course, very relevant aspects to decide whether a lesion really needs predilation, special plaque preparation, let's say, or just normal predilation. You can see that this patient,
so
for example, in this case,
326 degrees of calcium is huge calcification.
Yeah, so
concentric.
it's almost circular, almost concentric,
and
it's also very
in
thick.
The profile, you can see it highlighted in orange as well. Is that correct?
Yes.
So we can see that it's very focal.
The profile just is indicating the regions where the system has detected presence of calcium. So yeah, it's very focal. You can see it's a very tight stenosis, but you can see that there is a very concentric calcification, very thick, more than 1 millimeter in many of the points. You can see it's very thick, very calcified at this point. So I wanted to show you also how you can see the co-registration images to determine where does this exactly frame corresponds in angiography. And you can see here nicely shown where does this severe calcification where it's located in the angiogram. And we're going to move now after seeing the morphology and the presence of calcium that is significant in this case. It should be a warning that we need to prepare properly this plaque. We're going to move to the second screen, which is the measurements. It's the second step, let's say, of the MLD. It's length and diameter of the stent. The region that the system has selected here is pretty okay. You can see actually that the patient has some disease more proximal, but probably we don't really need to go very, very much proximal.
Agree.
Probably this area is fine, where you have this auricular branch. It's always a good area to land the stent. If you have a bifurcation, it allows a little larger stent, probably without problems of dissection.
And perhaps it's also the time of saying that you see a dotted white line, which actually is a very important new feature of the system. And this is the automatic identification of the external elastic lamina by the system that is powered with artificial intelligence algorithms. So it is really impressive. And you can see that it certainly provides a much better appreciation of what are the contours of the vessel, defined by the external elastic lamina.
In this area, for example, of the lesion, the system has been able to detect the EEL in around 180, and it's indicated with this dotted line. So this is, of course, very useful for the references and for the selection of the landing areas and selection of the size of the stent.
So it's telling us that the vessel Nieves will be around 4 millimeters. The external elastic lamina here suggests that the vessel is 3.99 millimeters.
Yeah, you can see that there the the EL is visible again around 180. There is a side branch here, so always the vessel size estimation is a bit more complex. But you can see that it's not reaching the amount of EL for the system to really provide you with a measurement. We have the lumen at this area, which is 3.5. So yeah, this would be like the proximal reference. I'm going to move now in the pullback to select a region for distal landing.
Perhaps we could also zoom the profile, Nieves, because then we can show to the colleagues that you can see that in the profile now you have also these white lines that run parallel to the lumen of the vessel. This is actually the external elastic laminate. So you have an appreciation of what is the size of the vessel at that particular location, whenever it is possible to identify it, of course.
Yeah, maybe around here we could select our distal landing. I mean, there is some disease at this level, but there is a very, very big lumen area at this point. So probably we don't really need to go much farther or go to the bifurcation. Yeah, so it's really, I mean, like you can have all these measurements quite easily from the table. And you can see that with this, we can now select the diameter and the length of the stent. You can see here with the two references we have selected, we would need like an 18 millimeter stent. And you can see also the references. Actually, we don't see very well the external elastic membrane in the two references that we have because the vessel is diseased. But we have a good estimation of the lumen also in the MLA area, in the minimum luminal area.
Yeah. But
I think probably 3.5 would be the idea because we have a lumen of around 3.1, so we can go a bit above this. We know the vessel will be larger than this, so we can always go to the next size of the stent that would be around.
So that was a great demonstration of the system. I'm just going to ask perhaps Lawrence what he thought about firstly the lesion, and secondly, just a couple of words about the system and how it looked.
Thank you, Adrian. So overall, I'm quite impressed. I have not myself used the system so far, but I think two issues are very much notable. First, the system guides the operator in a very systematic step-by-step way through the procedures, and notably prior to stent implantation, as we just have seen, and also we will still see that after stent implantation. So I think it's a very important and big step towards a standardized use of intracorneal imaging. That's something which was not taken into account so far too much, and was one of the key limitations that is addressed. And the second most important issue is probably the integration of an AI-based algorithm to first detect calcium, one of the clear-cut enemies of a proper PCI, and we're going to discuss this probably more in detail. And the second is the EM detection, which is important for stent sizing on the one hand, and on the other hand, to define the safety margin, for example, for post-dilatation. So these are really the two very important aspects that I see now based on this very nice case that Javier and Nieves presented. Regarding the calcium, I think it's important to note that with the automatic calcium detection, we were able to appreciate that the calcium is almost circumferential, has a thickness of more than 0.5 millimeter, actually 1 millimeter, and has a longitudinal extension of more than 5 millimeters. And we know from a large study that if you have all of these three findings, the chance that your stent will not appropriately expand after routine lesion preparation, like non-compliant balloon, then you probably have a high probability that the stent will remain underexpanded at the very end.
Perfect. I mean, absolutely spot on. And of course, there are any number of issues, as you and I have talked about before. Trials where imaging has been done, but people haven't acted on the images. And now the AI is telling you, look, doctor, look where the calcium is. And it's drawing your attention to it. And of course, it's then allowing us, almost telling us, you've got to plan this. You can't just do what you always do for every single lesion. And to a certain extent, certainly I'm old enough to have been brought up like this. We started off and we used to call it palpating the lesion, which meant you just put the normal old balloon in and see how you get on. The point you've made, which is so fabulous, is that not only can we improve patient safety by not doing that, but also potentially we can also improve costs. So this is a really great step forward in how we interpret imaging, how we learn from imaging, and how ultimately we affect these improvements for our patient outcomes. So with that, let's see what the guys in Madrid did and see which technology they chose. I suspect I know, but let's see what they did.
Because we have concentric calcification very thick, so it looks like a very good type of lesion for using lithotripsy. And we have seen that we have been able to advance the previous year, so let's see how the IVL balloon goes here.
So Niels, let's try first to advance the system without guiding catheter extension.
Yeah.
Of course, I mean, we have to remember, and this is something interesting from what we saw, if we want to advance the guiding catheter extension, we have a calcific nodule in the ostium of the circumflex, which may be a small obstacle. So, knowing that this type of information will improve the safety of the procedure.
So here you can see in this view the two references we have selected in white, and you can see here in yellow is the area of calcification that we're going to be treating. So it's actually pretty useful.
Good. I think this is a good location. Yes. So we go to 4 atmospheres.
Yeah. So let's go to 4.
We are showing you basically the way that lithotripsy works. You are seeing some images at the same time that we are performing the actual case. You may see actually the generation of the bubbles, the same bubbles that you see on the top here. Okay. And we deflate now. Yeah. Yeah.
But it improved already, from the first shocks, and you can see it improving.
And you can see the generation of CO2 bubbles inside the balloon as a consequence of the sparks. Okay.
I mean, it looks very good.
Definitely looking better.
Yeah. Looks very good already.
And this is very good news because then we can go directly to stent expansion, without further predilation.
Mm-hmm.
I think it's always very good. I mean, we know that the balloon has, at only 4 atmospheres, was able to expand this. So in case that there is any recoil in OCT, we know that, it's we have modified already calcium, and that at the time of bringing the stent, we will be able to expand the vessel again. But it's very good to understand the action that IVL has had on the plaque. With any technique, of course, not only IVL.
Catheter in. So going from proximal here to distal, we have this large branch. Here we have the calcified nodule in the proximal part of the circ. You can see that there is disease in all the vessel, and you already start to see here some of the cracks. And here you see a lot of these lineal cracks generated by lithotripsy. What is also evident is the very significant increase in lumen area obtained with these dilations with only 4 atmospheres, but using the shockwave system. So
very good. I think it's very convincing that the plaque has been nicely modified by IVL. We move now to the MAX, which stands for deploying of the stent first, and then checking for medial dissection, apposition and expansion.
Yeah, and expansion.
And for the deployment of the stent, we have a very interesting tool. Is that correct for this? I think that it's a new feature of the OCT.
Yes.
Where we can actually have as a reference the co-registration with angiography and real-time fluoroscopy. But now let's first speak about the stent. So I think we
decided to go a 3518.
3518 Science Sierra stent.
So this is this new feature Javier was talking about that is very useful actually for stent implantation. You can see on the right panel the region that you have selected for treatment with the references. And on the left panel, you can see your angio life, so you can really guide your procedure knowing exactly where are your references.
Our colleagues will be interested because we can see in real fluoroscopy. Can you give me some injection here? And we can make sure that you know that we really mimic the location that we have identified in the co-registration with OCT, which I think basically will be something like this. Do you agree? Well, let's check it again if you wish.
I think we have the proximal, this branch. It's a very good marker, so maybe a little bit more proximal.
I think that probably is the best place. Yes.
Yeah, so it's, we have this proximal marker that we wanted to choose as reference. So I think it's a good place. I'm going to deploy it. 12. You can see a very good expansion. I'm only at 12 atmospheres. You can see the stent is opening very well. We can check in another view.
Typically like to do some rotational angiography here. It's, of course, just moving your gantry, the C-arm with your hand. It's not a special feature, this rotational angiography aspect. But ensures that you have homogeneous of the... And now let's apply the max part of the
algorithm, yeah. So you can see the lumen profile, and here the lumen profile is indicating where is the minimum stent area located, and you can see that actually here the system had some problems in really detecting the real luminal area, and this is probably related with the shape of the stent in this area created by the calcification. You can see that the stent looks quite eccentric at this level. But you can see that proximal and distal to that, the system has properly detected the lumen, and you can see that the expansion is actually really good. Can we correct? We're going to correct this area that is not measured properly by the system.
¿Nos la quieres corregir tú, el área esta? Venga.
Sí. Okay. As we said before, we have the max part of the algorithm, and from the max part, in my opinion, the X is the most important part, the expansion. And you can see here nicely displayed in the profile of the lumen and the stent. You can see that the system is indicating the minimum stent area and the expansion at this level, and you can see that even in the area of minimum expansion, we are above 100. So we have good expansion. Second part is a position that we're going to check now in the pullback. I think what I'm going to do is plane the pullback here. You just saw the edge, that there were no dissections at this level. And we're also going to check the apposition that, as you can see, is good. There are some areas of minimal malapposition that is basically created by the shape of the lumen, by the protrusions of the calcium inside the lumen. Really, there's no way that the stent is able to adapt to this, to all these shapes. So you can always have some degree of malapposition that is not really relevant. And you saw already the distal edge. That is that, as you can see here, there is no dissections at the proximal edge. We just landed close to this branch where we wanted. And if we go to the distal edge, also no dissections at this level. So good expansion, good apposition, just minimal malapposition, just created by the shape of the calcium, and no edge dissection. So I think we are ready with the procedure and with the algorithm.
I think I agree. I mean, the other aspect, of course, is that we see that the matching of the size of the vessel with the stent was perfect. You can see that there is virtually no difference whatsoever between the size of the lumen and the stent area immediately at the edge of the stent.
Yeah.
So it's really good. And as you say, you really have to understand that in these type of vessels, first presence of calcium, second bends, etc., there is always a few struts that will not be fully opposed, and that is not going to be, it will not be possible to correct that.
And
so
probably
I
it's
agree.
not relevant.
It's a very good point. So my suggestion, Nieves, is just I'm taking out the OCT catheter, and then we perform the final injections into angulations as we typically do. Very good. You can see the spicule of calcium that we saw in OCT at the top, but of course that is not flow limiting, and that is something that is not the objective of our treatment.
Yeah.
Great. So I think it was a case full of didactic messages, Nieves. Really, of course, a great opportunity to share with the colleagues the value of this new generation of OCT software, the ULTREON system. We really hope that you have enjoyed the case. We are very thankful to the patient who kindly agreed to share with all of us his intervention. And we wish you a very good course. Thank you.
Thank you.
Niels, Javier, fabulous case. Very elegantly showing us the value of imaging and allowing us to choose, the right technology. So Niels, two questions for you. Presumably, lithotripsy was much better than rotablation for this case because of the distribution and the anatomy of the calcium. And secondly, tell me a little about, colleagues say, it takes too long, it's going to take me too long to do imaging. Tell me what you thought about the workflow and how that kind of worked for you in the lab.
Yeah, so I think this was a very good case for lithotripsy, this kind of concentric calcification, thick. It looks like an ideal case for lithotripsy, very focal. And it worked very well, as we demonstrated in the case. And about the procedure, I think it's very important what Lawrence said before. I think that having the in this structured way that ULTREON provides really facilitates a lot the implementation of imaging in the workflow of the case. I mean, it's a tool that you use during your case. You don't have to really go out to make measurements, etc. You can do everything from the table. Everything's a structure, the steps that you need to follow. So especially for people who are not maybe that familiar with imaging, is a great way to guide them during the procedure and implement imaging in the normal workflow of the case.
As with lots of technologies, the quality of the imaging is clearly important. I think you use an automatic injector. Presumably that would be a recommended use for this technology.
Yeah, we use automatic injection. Yeah, and I think it's preferable. There are also new ways now trying to perform OCT with less contrast, saline injection. So I think it's a field that is also evolving, and maybe we will have new ways in the future, maybe also reducing the amount of contrast. But actually, this is also an important concept. I think that really performing the pullbacks in the right moments can even save contrast. So you don't really need to do a lot of angios in the middle, because you do an OCT, you get the angiogram and all the information of OCT. So you don't really need to do another view, for example. So if you perform the pullbacks in the right moments, this can be also a way to limit the amount of contrast that you use during the procedure.
Javier, in Syntax 2, we tried to kind of combine physiology and imaging to improve our outcomes in multivessel disease. Are we at a point now in complex PCI where imaging is really essential, do you think? Where do you stand with that?
Well, absolutely. I think obviously Syntax 2, for the colleagues that are not very much aware of the study, was a study that investigated a compendium of best practices. And of course, imaging and physiology were two of these two practices. But it's true, Adrian, that the technology and the strategies kept moving, and the way that we use imaging at that time is cannot rival actually with the amount of information that is being displayed in front of you, as you mentioned before, with systems like this, where you are shown in a very intuitive way, you know, where the calcium is located, for example. And not only that, you are provided with quantitative information like the thickness of calcium, the arc of calcium. All this can be customized. You can decide if you want to see or be alerted of an arc of calcium of more than 180 degrees or less or whatever. So my impression is that, you know, I'm sure that in the future there will be new iterations of the Syntax 2 strategy. It will be a Syntax 2 strategy 2.0 or whatever that will test the value of all these developments on the outcomes of PCI in the long term.
Because I think we've got to the point, you know, it was almost a lazy attitude we had as interventional cardiologists, that we blamed target vessel failure, target lesion failure on restenosis. You know, for most cases, and of course there are exceptions, but for many cases these days, lesion failure is down to technique and incomplete expansion or incomplete plaque coverage. The fact that the case was left without the best job being done. And, you know, I rejoice in the fact that we've moved from a position where perhaps 20 years ago, the best cardiologist was regarded as the fastest cardiologist, to the position where actually we're taking our time to make sure we do the job well. And I think some of the messaging has come from TAVI, you know, rather than just kind of getting on and doing it. And I think we saw a fabulous example of that with OCT. Now, going forward with AI, you know, it's going to be interesting where we go. And perhaps I'll just ask Lawrence to give us a last word on where he sees artificial intelligence taking the next step for us with regard to not only telling us or indicating what is there, but also telling us perhaps what to do and why not to do this. How do you see it going, Lawrence? Where will we be in 10 years?
Well, a good question. In 1 or 2 years, hopefully AI is supporting the lumen contouring, first of all, because as we have seen, there are still some frames where the lumen is incorrectly traced, and that would be very helpful. In the future, I think the estimation of the physiological relevance obtained by the imaging information will be a key step forward, and I think there's a lot to come in that perspective, and I'm very much looking forward to this next step.
Perfect. Well, this has been a fantastic session sponsored by Abbott. We've seen some great application of new technology, looking at how, using the ULTREON system, we can guide our intervention to use the right technology in the right lesions at the right time to ultimately optimize our outcomes for patients. I contend that by doing that, we will move through the lab quicker, that we'll probably save money during the intervention, and perhaps most importantly, our long-term outcomes will be better. So I hope you've learned from the session. If you have questions or things you'd like to raise with us, please let us know. We'd be happy to answer that. I'd like to thank Abbott again for their sponsorship and ask you to enjoy the rest of EuroPCR. Thank you very much for your attention.